In this session, we will look at some of the body's defences against diseases. The first line of defence is inflammation. When you think inflammation, you think swelling, redness, and pain at that site. And so we're going to look at analgesics, antipyretics, which block the fever that often goes with an inflammation due to an invading organism. And we'll also look at anti-inflammatories. Firstly, the non-steroidal anti-inflammatories, the NSAIDs, and of course the steroids. We'll look at some antihistamines, some disease-modifying anti-rheumatic drugs or DMARDs, and drugs used to treat gout. So first of all, the body's resistance to disease. We're looking at both the non-specific mechanisms and specific immunity. With the non-specific mechanisms, we divide them into physical barriers, such as the dryness of your skin, and chemical barriers, such as the mucus that is produced at mucous membranes, and some of the enzymes that it contains that non-specifically kill microorganisms. With the specific immune reactions, we're looking at an acquired immunity via either antibody or cell-mediated immunity. So when a foreign microorganism invades, it first meets your chemical resistance mechanisms. These try and eliminate the organism from the body. And then if that doesn't happen, the second line of defense, an immune response. So then when we look at the goals of therapy, first of all, we will look at drugs which will treat that initial inflammatory response. The diseases will involve a lot of pain and stiffness at those joints, and so these anti-inflammatories will help reduce that pain, reduce the stiffness. This will help to increase mobility and minimize disability, and a lot of these diseases, as we will see, are move it or lose it type diseases. If this can happen, then this is going to prevent and minimize any deformity that might happen. And another goal of therapy will be to improve the quality of that person's life. In addition, we may wish to do immunosuppression because of all of those cells and antibody responses that lead to those immune responses. We may actually wish to inhibit inflammation by inhibiting the cell migration, which leads to that swelling associated with inflammation. The name for the way the inflammatory cells migrate to the site, the white blood cells, is chemotaxis. We may wish to inhibit the release of inflammatory enzymes, and we may wish to inhibit certain mediators, the prostaglandins, symbol PG. These are inflammatory mediators or cytokines that are produced by various white blood cells and initiate and regulate inflammation. And so inhibiting them will help to reduce or block that inflammation. The drugs treatment strategies that we're going to use, they will be for various diseases, particularly those that affect the joints. So we will be looking at gout, rheumatoid arthritis, osteoarthritis, and the drugs that are indicated for these conditions. Even though there's a number of different diseases, they have a number of common characteristics. So the same drug will be used even though there are many different diseases. So non-steroidal anti-inflammatories could be used to treat all of those above joint conditions. Oral corticosteroids could be involved. We'll also look at paracetamol and the DMARDs, if you can remember, that's disease-modifying anti-rheumatic drugs. The non-steroidal anti-inflammatories, NSAIDs are one of the most commonly administered groups of drugs worldwide. In Australia, 10 million of them were prescribed. So this is separate from where people may have self-prescribed over-the-counter medications for a range of diseases, including inflammation and joint diseases. This is just those that were prescribed, 10 million. In addition, there was a lot of over-the-counter drugs sold. 60% of most medications sold are over-the-counter drugs. There were other therapeutic classes. There were analgesics and antipyretics. The analgesics block pain, and pyrexia is a fever, so antipyretics are things like paracetamol, which will block that fever. The mechanism of action of the non-steroidal anti-inflammatories is that they inhibit the biosynthesis of those mediators, the cytokines known as prostaglandins. They're cytokines because they're produced by a white blood cell to influence the clonal activity or the cellular responses of other white blood cells. If you can inhibit prostaglandins, you will reduce the inflammatory response. There are at least 2 enzymes involved in the synthesis of prostaglandins from arachidonic acid. These are cyclooxygenase enzymes, COX. The 2 types are COX-1 and COX-2. Inhibition of the COX-1 pathway was part of the reason for a lot of the adverse effects seen with the non-steroidal anti-inflammatories, and this led to the development of COX-2 inhibitors, and in this pathway it addresses the inflammatory process and they tend to have fewer adverse effects. Let's have a look at those 2 pathways. First of all, COX-1 pathway on the left. There is a physiological stimulus. This leads to an increase in phospholipase A2 activity. More arachidonic acid is made available. The COX-1 and COX-2 enzymes turn that into, first of all, an intermediary and then many other cell mediators after that. Thromboxane A2, which affects platelets. Prostacyclin, also known as prostaglandin I2, it affects the vascular endothelium. And PGE2, prostaglandin E2, which affects the kidneys and blood vessels. The consequences of COX-1 and COX-2 inhibition by the non-steroidal anti-inflammatories will therefore have ranging effects from blocking at this pathway to block bleeding. However, at this pathway, it could lead to some adverse effects such as gastrointestinal ulcers. And through this pathway, they could affect decreased renal function, therefore sodium retention. In the COX-2 pathway, there is some outside stimulus, inflammation, or some mitogenic stimulus, stimulating mitosis. Once again, a phospholipase A2 enzyme makes arachidonic acid available for these other uses. Its major use is as part of cell membranes. When some free arachidonic acid is made available after this stimulus, it is converted once again to the same intermediary and then to PGE2 and PGI2. So PGE2 was the one that led to the kidney effects via vasodilation. The prostacyclins had effects on platelet aggregation at the vascular endothelium, and there were many pro-inflammatory prostaglandins produced as well. By inhibiting the COX-2 pathway, you've inhibited the inflammation, the fever, and the pain, as you did with the COX-1 pathway. But you will not have so many side effects on the gut. Note that there will still be side effects on renal function and perhaps some increased sodium retention. COX-1 involves several homeostatic functions in the body. Inhibition of this enzyme is the reason for most of the adverse effects with the nonsteroidal anti-inflammatories. They inhibit a mucoprotective prostaglandin in the gastrointestinal tract, explaining why most of the nonsteroidal anti-inflammatories cause severe gastric adverse effects and peptic ulceration. This explains why a lot of people won't take aspirin and will take other preparations which are less damaging on their gut. The newer drugs that inhibit via the COX-2 pathway still are anti-inflammatory, and this pathway seems to then be the most appropriate to target when trying to reduce inflammation and pain, because you won't get those same severe gastric adverse effects. The nonsteroidal anti-inflammatories include aspirin, which is a salicylate, coxibs, celecoxib, which is sold under the proprietary name of Celebrex, various propionic acid derivatives, so ibuprofens, that's the generic substance, but it might be such proprietary preparations as Nurofen, Advil, Naproxen, Femfree, and Naproxen. There are various indole acetic acids, which are nonsteroidal. The indomethacin, generic name, and the proprietary preparations Arthrexin, Indocid, diclofenac, and Voltaren. There are various drugs which are phenamates, a particular chemical class, such as mefadamic acid or Ponstan, and lastly the oxycams or a particular generic type piroxicam, proprietary names Feldene and Mobic. The formulations of these nonsteroidal anti-inflammatories are made so as to reduce that COX-1 pathway specific adverse effect of peptic ulceration and gut irritation. So they will come in an enteric coated, or they may be parenteral suppositories, or like Voltaren might be a topical administration. Suppositories, though, will have their own adverse effects. Topical formulations have limited efficacy. They don't tend to have any delivery to the joint itself, and so aren't actually anti-inflammatory at the site of the pain. The indications for nonsteroidal anti-inflammatories will be any mild to moderate pain. Any fever, they are antipyretic. Of course, inflammation, they will prevent platelet aggregation. The best of them is still aspirin. They will be indicated for rheumatoid arthritis, which is a chronic condition. Osteoarthritis, once again, its main indication for the use of nonsteroidal anti-inflammatories. Once again, it is chronic use of these drugs to treat a chronic illness. And there are various acute and chronic musculoskeletal and soft tissue inflammations for which they will be indicated. The pharmacokinetics of the non-steroidal anti-inflammatory drugs are that they are absorbed quite well when given by the oral route of administration. Food might delay absorption, but does not change the total amount of drug that is absorbed. They show a high protein binding in the plasma. They will mostly bind to albumin. In the free drug state, they are metabolized by the liver and excreted by the kidneys. The adverse effects of the non-steroidal anti-inflammatory drugs therefore include gastrointestinal, dyspepsia, nausea, vomiting, diarrhea, constipation, gastritis, and, as we said, may potentially lead to ulceration, particularly peptic ulceration and hemorrhage. You saw that they are used for osteoarthritis and rheumatoid arthritis, chronic illnesses, and so chronic use. And this may, over time, lead to peptic ulceration and hemorrhage. But in addition, the non-steroidal anti-inflammatories might cause skin rashes, skin reactions. If they're a COX-1 inhibitor, they may lead to that sodium retention. Because they are excreted by the kidneys and have vascular effects, particularly the COX-1 pathway inhibitors, they will do renal damage, and this could affect heart, leading to heart failure and hypertension in some patients. The non-steroidal anti-inflammatories may precipitate an asthma attack. There are also additional drug-specific adverse effects. This leads to various contraindications for the non-steroidal anti-inflammatories. So when I read out that list of proprietary names, some of them would have been familiar to you, and you would have recognized a lot of them as over-the-counter medications. And so it's important to understand that though they are over-the-counter, they need to be used according to the instructions, and these instructions need to say these following contraindications, or perhaps it's just a caution. So asthma, contraindicated. Caution in elderly patients, in debilitated patients, because they will have concomitant heart and kidney diseases, perhaps liver diseases. Caution in people with a compromised cardiac function or hypertension, even if they're not elderly. Once again, a caution, avoid the use in people who are hypersensitive or have a severe allergic reaction to aspirin. Contraindicated in severe renal disease or severe liver disease. Contraindicated in people with an ulcer or gastrointestinal tract bleeding. And once again, though they're over-the-counter medications in a lot of cases, but also a lot of them prescribed medications, there will be many interactions. They will interact with antihypertensives, particularly the diuretics, due to those effects in the kidney. So this is an interaction based on the pharmacokinetics of the drug and their excretion from the body. They will interact with cyclosporins and other nephrotoxic drugs, raising their levels in the plasma, and so therefore leading to greater adverse effects. Lithium is not reabsorbed so well by the kidneys, and therefore rises in plasma concentration. Lithium is one of those drugs that has a very narrow therapeutic index, meaning the range of concentrations at which it is therapeutic is very close to the range of concentrations at which it is toxic. So if you're taking non-steroidal anti-inflammatory drugs, that can put you into toxicity with lithium. We will look at methotrexate as a drug that can be used to treat various immune disorders, but its commoner use is for cancer therapy. However, it has interactions with non-steroidal anti-inflammatories. Probenecid and warfarin also interact. We looked at various chemical classes. The first one was the salicylates. The best example is aspirin. The mechanism of action of aspirin as a non-steroidal anti-inflammatory is that cyclooxygenase inhibition. Because it operates via the COX-1 pathway, it has those effects on clotting. It can lead to a lasting deficit of platelets, a thrombocytopenia. So this is one of the contraindications then specific to that particular drug. Aspirin is an excellent analgesic for mild to moderate pain. It's an antipyretic, which means it will block fever, as well as being an anti-inflammatory and showing that antiplatelet activity. So one of its proprietary names is Cardiprin, given to people who have chronic heart problems where you wish to make the blood less coagulable. So you give low doses of aspirin to avoid that gut irritation. Aspirin has its analgesic effect at blocking pain, but once again via a prostaglandin pathway in the body. Prostaglandins make peripheral nerve endings sensitive to inflammation and make them more sensitive to other pain mediators such as bradykinins. Aspirin may also have central nervous system actions. Once again, central nerve endings are affected by prostaglandins, especially prostaglandin E1 and E2. If you are blocking these pain mediators, then there is some CNS reduction in pain, so an analgesic effect peripherally and perhaps centrally with aspirin. However, aspirin, as we said, only effective against low to moderate intensity pains. Certain somatic areas of the body respond better, such as headache and uterine spasm. In the antipyretic effects of aspirin, they're once again blocking prostaglandins. It would appear that prostaglandins reset the thermostat in the hypothalamus to a higher setting. So if you can block that prostaglandin production in the hypothalamus, then you will inhibit that fever and keep the temperature down. Aspirin has its anticoagulant and its so-called antiplatelet effect by inhibiting the formation of thromboxanes from that intermediate made from arachidonic acid. However, it also blocks production of prostacyclins, and prostacyclins are one of those natural mediators of coagulability. There are a lot of other mediators that are produced by the vascular endothelium that block the effects of prostacyclin, operating in a homeostatic balance to keep the blood in hemostasis. And in people who are prone then to clotting, you would wish to block the effects of the prostacyclin, and aspirin is indicated here. Thromboxanes and prostacyclin are cytokines. They affect other cells, as we said, platelets. They make platelets aggregate. So when we say aspirin has an antiplatelet effect, we mean an antiplatelet aggregation effect. Aspirin is used in the language that your clients will use to thin the blood. The correct term, though, is to just retard clot formation, make the blood less coagulable, and make platelets less inclined to aggregate. This is important in the arterial circulation, and this is why aspirin is indicated in people who have some sort of cardiac problem. Because of the anticoagulant and antiplatelet effects of aspirin, it can be prescribed for the following conditions: arrhythmias, strokes, post-myocardial infarct, TIAs, transient ischemic attacks, angina, and peripheral vascular disease. It's only a low dose in these cases as a prophylactic preventative measure. There are many formulations of aspirin: slow release, enteric coated, and dosages from 100 milligrams through to 300 milligrams per tablet. The dose is designed for whichever indication. A low dose will be antiplatelet and anti-inflammatory, usually at the higher doses. You can get buffered dosage forms and soluble forms that do cause less gastric irritation because they are readily absorbed by the stomach. The activity appears to be enhanced when combined with caffeine, so they may be found together in a fixed dose formulation. The indications for aspirin, once again you'll see that it's low-grade pain. Then those chronic conditions, and then of course as an anticoagulant and antiplatelet in the two asterisk conditions. So we have pain, fever, and because they're analgesic and antipyretic, indicated for headaches because of its analgesic properties, indicated in rheumatoid and osteoarthritis because of its non-steroidal anti-inflammatory properties, and myocardial infarct and stroke. The pharmacokinetics of aspirin, very rapidly absorbed, partly from the stomach. This is increased, of course, in those soluble and buffered forms, but of course mostly then from the intestine, reaching a peak serum concentration within 20 to 40 minutes. It is distributed through most body tissues, and as we said, very high protein binding, anywhere between 50 and 90%, and it will go through hepatic metabolism. Recall that if a person has any liver disease, this may contraindicate the use of aspirin. So to go through those adverse effects specific to aspirin, the gastrointestinal bleeding and ulceration. There is a prostaglandin-induced protective mucus in the stomach, and because you're blocking prostaglandin production with the aspirin, this can then reduce that protective mucus, leading to the gastric bleeding, and over long-term chronic use leading to ulceration. So it has gastrointestinal tract effects, the nausea, the vomiting. These are usually at the higher doses. And of course, alcohol consumption at the same time can worsen these gastrointestinal effects. Taking aspirin may prolong a person's bleeding time. Aspirin may cause tinnitus, ringing in the ears. It might cause dizziness, deafness, but once again, usually the larger doses. Remember, contraindicated in people with asthma. Aspirin does cause allergic reactions. This can lead to bronchospasm, itchiness, which is urticaria. It can lead to hay fever. This is a very rare reaction. The last final adverse effect of aspirin, it will cause renal damage, but once again, this is in the high doses and over the long term, and related to the fact that aspirin is excreted from the kidneys. specific contraindications for aspirin. It is contraindicated in people with hypertension. It does have those vascular effects where that could worsen the condition, and so as a consequence also contraindicated in heart failure. We've already mentioned that for most of the non-steroidal anti-inflammatories, particularly the salicylates, contraindicated in renal and hepatic impairment. It is contraindicated in those about to undergo surgery because of that prolonged bleeding time. It is contraindicated in peptic ulcer disease, asthma, late pregnancy. We do not want prolonged bleeding during childbirth, so contraindicated in late pregnancy. There is a neurological syndrome, Ray's syndrome, that could perhaps happen with children under the age of 18 years. And so you will notice that most of the formulations available for children are paracetamol and not aspirin to prevent this Ray's syndrome. Aspirin has many interactions. So there we have some of the ones that we have mentioned. I'll mention a couple of them. Of course, it will interact with warfarin due to the fact that they both have the same pharmacodynamics. They're both anticoagulants. It will interact with non-steroidal anti-inflammatories, once again by a pharmacodynamic interaction where they're both inhibiting the same pathways. But in addition, aspirin will interact with antihypertensives. In a lot of cases, that's a pharmacokinetic interaction related to the fact that they both work in the kidneys. They are excreted, aspirin is excreted in the kidneys. Antihypertensives, such as the diuretics, have their mode of action there. With these next few drugs, it's that the levels in the serum are affected. They will interact with corticosteroids. They will interact with probenecid. They will interact with valproate, which is indicated for grand mal seizures. And some of the very important herb drug interactions. Aspirin will interact with ginkgo, ginger, and garlic. Paracetamol, the name Panadol is used as if it is the same as paracetamol, but as you now know, paracetamol is just a generic name for the active ingredient, and Panadol is one particular formulation for which one company has a trademark. Paracetamol is used as an analgesic and an antipyretic because it has little to no anti-inflammatory activities. Its indications then are for fever, once again mild to moderate pain, such as headaches, migraine and tension headaches, and some joint conditions. It is useful long-term for osteoarthritis. The mechanism of action for paracetamol isn't completely understood. Does appear to be a COX inhibitor, but it has that very little anti-inflammatory effect, so that particular pathway not affected. So it can also act centrally, and this may be its main mechanism of action. It inhibits prostaglandin synthesis, once again in the hypothalamus, and this will reduce pain and fever. The pharmacokinetics of paracetamol, once taken orally, is very rapidly absorbed. It can reach its peak serum levels in 15 minutes for some people to 1 hour. The elimination half-life is 1 to 3 hours. Paracetamol is metabolized in the liver. We'll see this is very important for its toxicity. It is excreted as glucuronide and sulfate metabolites so that it can be excreted by the kidney. It does also deplete glutathione in the liver, and we'll talk about that shortly. So the adverse effects of paracetamol: At the therapeutic doses, so if the instructions on the labelling are followed, there are very few side effects. They are mild. It is definitely not associated with gastric side effects, so it does not affect that prostaglandin which has that mucoprotective effect. Paracetamol is not associated with a high incidence of drug interactions or drug-herb interactions. Paracetamol has an excellent safety profile. We keep stressing once again that's only if you follow the instructions. There is a small incidence of some significant adverse effects, nausea and rash associated with the use of paracetamol. However, the most worrying thing with paracetamol is its toxicity. Liver toxicity is rare. It is linked to the use of large quantities of the drug itself or alcohol, so an overdose situation. There are some very important safety concerns with the use of paracetamol in high doses. Overdose could damage the liver, can damage the kidneys, can cause hypoglycemia. This could lead to coma and death. A dose of 10 to 15 grams, which would be 20 to 30 tablets, will cause severe liver damage due to depletion of glutathione. This could lead to death. A dose of 50 tablets needs to be treated with the antidote acetylcysteine. This protects the glutathione levels. Corticosteroids are used in the management of rheumatoid arthritis. As with the non-steroidal anti-inflammatories, this doesn't alter the progression of the disease. It's a management of that disease, ensuring that the person, because they have a better quality of life and less pain, is able to exercise more and prevent the progression of the disease. The mechanism of action is both anti-inflammatory and immunosuppressive. So here we're saying it will work on the non-specific immune responses and specific immunity. It can be used at various stages in the progress of rheumatoid arthritis. Once again, it would appear that it's via inhibition of prostaglandins and leukotrienes, which are another cytokine, chemically similar to prostaglandins. The corticosteroids, because they also have immunosuppressive properties, impair migration of monocytes, lymphocytes, and neutrophils. They impair release of proteolytic enzymes to the affected area. The sum total of all these effects is to blunt inflammation and any autoimmune responses. So very good in rheumatoid arthritis. Corticosteroids suppress vascular and cellular events via that suppression of inflammation. It is both the immediate responses of inflammation and any late responses, such as wound healing and repair, that are also suppressed. Because of their immunosuppressive properties, corticosteroids can lead to atrophy of the thymus as its T-cell population decreases. These T-cells are one of those types of lymphocytes. They can also then decrease the number of plasma cells and eosinophils in the blood. By that action of blocking prostaglandins and leukotrienes, they interfere with the roles of both the T and the B lymphocytes. Not only do they reduce the number of the monocytes and thereby the macrophages, they also affect their actions by blocking the production of the cytokines. These lymphocytes and macrophages are involved in immune and allergic responses. Corticosteroid adverse effects are many. So I've grouped them there. We have certain effects on the gastrointestinal tract. They will have effects on fluid retention. The hormones produced by the adrenals do the same thing, how they tend to cross-react, how a glucocorticoid can act like a mineralocorticoid would and can affect fluid retention. So the corticosteroids mimic the effects of the natural hormones and can also have adverse effects on fluid retention. Because of their effects on metabolism and these effects on fluid retention, they can lead to a very full face, a Cushingoid face. They have various systemic effects and effects in the eye. They can lead to depletion of calcium from the bones and osteoporosis. Because they impair the later stages, not just the immediate stages of immune response, they can impair wound healing.